Thank you for joining us today. My name is Jody McGinnis Porter, and I'll be moderating today's press conference. Today, Dr. Scrace will provide an update on COVID-19, and Dr. Podahan will provide an update on monkeypox. After the presentations, we will take questions from our media partners. When we get to the Q&A portion of the press conference, we ask that our media partners raise their hand in Zoom if they'd like to ask a question. We will go through one round of questions, and if we have time, we'll go to round two to give each reporter an opportunity to at least ask one question. I'll turn it over now to Dr. Scrace to go through his presentation.
Thanks, Jody. I can't see myself on camera, so just want to confirm that I am on camera. I think I can see that now. Thanks. Thanks all for joining us again this month to give you an update. The summary is that COVID is pretty stable in the state, although we're still at a high level of cases, and monkeypox is the new infectious disease on the block that we're taking quite seriously now. And so these are really two presentations put together. But I'm going to start by going through what's happening with COVID, and we can go directly to the first slide. And you can see here, going all the way back to 2020 when the pandemic started till today, the blue lines are the number of cases each week, and the dotted black line, the thick line, is the average rolling 7-day average, and the red line is what CDC has declared as a high rate of spread. You can see that they changed that definition in March of this year, with the red line moving up. But in general, New Mexico has plateaued in cases. As you can see there, it's a pretty flat line. Not much evidence that it's coming down just yet, because those last few data points will be filled in later. You can also see, because we got some questions about this, how are we doing around the state? This is not the red, yellow, green, or the CDC orange, yellow, green map. This is just how many cases are we seeing per 100,000 people. So it's corrected for population. You can see, interestingly, that the corners of the state seem to have a higher case rate, not the Northeast, but and then even Bernalillo these days. But we're pretty much at a plateau. Next slide, please. And hospitalization side, another plateau. And I think it's important to notice here that hospitalizations, now we're in the B4, B5 wave of this pandemic, and possibly and probably the same number of cases we had when we had 709 people in the hospital, but now only 164, which means that the disease itself seems to be causing a lot less hospitalizations as a percentage of people who get COVID and this variant than previous strains. So that's good news for us, right? It's a less virulent, less aggressive variant in some ways. And you can also see that the number of ventilated patients has dropped down to just 6, and that's less than 4%. And by comparison, with Delta and the early part of Omicron, we were seeing 18 to 20% or more of patients admitted to the hospital on mechanical ventilation. So positive news on the front of how things are going. Not as good news is we have seen deaths go up again. They plateaued, and we, as you can see here, in the past week, it's recorded as 32. It's actually been higher than that in the past 14 days, Brianna, I think, because I know we've had double-digit days for quite a while. But in any case, the death rate, your chances of dying with the B5 variant appear to be much lower than they were certainly with Delta and the early part of with the other Omicron variant. So that's good news as well. I think we're still not out of the woods, and anytime you're having 10 deaths a day for a really long time, that means a significant impact on individuals and families and communities that we can't forget. But at the same time, the good news is less people being hospitalized as a proportion of total cases, and less deaths as a proportion of total cases. Next slide, please. I think you all know that CDC is now publishing community levels of transmission. We are using that and directing people to that website. This is based on the number of cases and the volume in hospitals in those areas. And so, interestingly, for the first time in about as long as I can remember, at least since the CDC started this reporting method, New Mexico has areas of red, yellow, and green. And you can see those highlighted with the square on the map. And I don't remember this happening since they started this new reporting. And so the CDC has guidelines for what should we be thinking about doing or doing if we're in low, medium, or high areas. And you can see about 1/3 of our counties are still high, about half medium, and about 1/5 low. I know those don't add up, but the percentages do. So you can use those. Let's go to the next slide. Just take another quick look at that. You can see that in those counties that are red, like Lee County and McKinley County, CDC and the Department of Health here in New Mexico recommend that we're wearing a mask indoors in public, recommending that everyone stay up to date with primary series and boosters for COVID vaccines. We're recommending that you get tested if you have symptoms. And if you quickly look across, you'll see every category you should get tested if you have symptoms. Then particularly in red times, in red counties, you want to be orange county, sorry, I call it red, but it's orange. You want to be careful if you're at higher risk. And then on the low side, stay up to date with your vaccines, get tested if you have symptoms. And medium is in the middle. I won't read it. Of course, you can choose to wear a mask at any time. People with symptoms or a positive test or exposure to someone with COVID-19 should really wear a mask. There's that great online website, the CDC Q&A calculator, still recommending it to people every single day that will tell you what to do if you have COVID or if you've had exposure to someone with COVID. And we think that advice is strongly researched and reliable, and would encourage you, if you're in either of those situations, that you check out that website, that being having COVID or being exposed. And then lastly, if you're immunocompromised or high risk for severe disease, the stakes are much higher. Please go to the website at CDC and read up on that, because you need to be even more careful than what the low, medium, and high levels from CDC would indicate here. Next slide, please. So good news for those of you with kids under 5, or those of you with grandchildren like me under 5. This is the time of year where kids are going back and getting updated on all their vaccines, and measles and mumps and rubella and all those different things, tetanus and all those things we use to protect against such serious illnesses. And so this is a really good time to think about the COVID vaccine for the for kids newly entering school, that 4 to 5 year old age group. Vaccines still provide protection against hospitalization and death. The existing vaccines still provide protection when you're given a booster against hospitalization and death. And so you can go online still and schedule vaccines at the DOH website, or just call your own primary care physician or pharmacy and make arrangements to do that. And we still encourage that and still strongly recommend it, because it's the most effective way to reduce your risk of getting serious complications like hospitalization or death, or even long COVID from the infection. Next slide. More good news. Novavex rollout is underway. I have a couple patients who haven't been vaccinated yet, and they have concerns about some of the elements that go into making up the messenger RNA vaccine. And so this is a vaccine that actually doesn't carry those concerns. It's the old school protein-based vaccine. It's antibodies against the spike protein and antigen from the spike protein, and that causes you to build antibodies. It was granted emergency use July 13th. I think we mentioned this last time. at the press conference. But now our government, President Biden has bought 3.2 million doses. The vaccine is available now. It says will be, but it's available now for people ages 18 and older. It's 2 doses, 3 to 4 weeks apart, like most of the other vaccines. We already have had 13 providers that have ordered the vaccine. We've shipped it to them, and it's now an option on vaccinenm.org, where you probably scheduled your prior vaccines. So it's out there. It's still not approved for boosters and things like that. And so we're waiting on some of those additional approvals that probably will be coming. We don't need to know that now, right? Because we won't need to know that for 4 months from now. And then lastly, the Pfizer vaccine that most of us, or many of us have received, actually most of us, is now off of EUA status, has full FDA approval. And so for those of you who are concerned about an experimental nature of a vaccine, that barrier has now been removed by the FDA. Next slide. Also, I'm really excited, and I've been talking about this for months. I think it's going to be really important that we enhance our response to COVID to keep up with it, and that we start updating the vaccines to be just as effective against Omicron variants as they were and are still against the previous variants. And so they still protect, but I think we're ready and need this extra booster shot that is directed against the new Omicron variants. And so this vaccine will have it. There's some evidence that the immunity lasts longer. We'll see how that plays out. Of course, the vaccine still needs FDA approval and the CDC recommendation, which we're hoping happens in September or early October. The government has already purchased 171 million doses for the United States. And in the meantime, if you're behind or overdue for a booster, there's no need to wait. You can get it now, and then you can get on board with the new booster with broader coverage. So I'd encourage you to do that as well. Next slide, please. So I'm wrapping up my part, turning it over to Laura. The key things we can all do when we all do our part are know our community levels. I just walked everybody through that again today, and follow the CDC guidance for low, medium, and high levels. I've already mentioned getting vaccinated, getting tested, so much easier to do now. I was recently on a vacation, just got back, long plane flights. We have our home testing available for use immediately. If anyone gets symptoms, I ordered them online just the way everybody can, and that's on our website as well. And then if you do get symptoms, please get tested and please get treatment right away. We're treating some weeks 4,000 people a week with Paxlovid. This is delightful news. Those of you who remember us at the start in February and March, maybe it was 100 people a week. And then in May and June, we got it up to 1,000 people a week. And now we're up to 4,000 people a week. It's a medicine that's right for almost everybody, but you do have to check with your doctor or a clinic that is treating COVID to make sure that if you're on other medications, there aren't any interactions. But I've been doing a lot of prescribing of Paxlovid myself, some prescribing of molnupiravir, and it's getting much, much easier to do. And you can also talk to your pharmacist about whether they can prescribe it for you as well. It's a new opportunity the federal government has provided, but we're just getting that. Our pharmacies across the state are now getting that up and running and deciding if they want to do it. And lastly, I still wear my N95 or KN95 mask when I go out. On the plane to Alaska and back, I wore an N95 and was really careful and had eye protection. And so let's be safe. Let's stay safe. We still have a lot of cases, but we have a less virulent variant right now. And let's stay tuned for new vaccine news that might be ready for all of us to boost our immunity to the newer variants that are coming soon. So that's my report, and I'm just going to turn it immediately over to Laura. Laura, you can go ahead and turn your camera on. And Laura is our designated expert on monkeypox, and she's also very graciously stepped up and is filling in. And after our epidemiologist left, is doing a good job while that search continues underway. And I'm just going to turn it over to you to tell us about everything we need to know about monkeypox, Laura. Thank you.
Right. Thank you, David. Well, yes, I'm going to share a little bit about monkeypox cases right now in the US and New Mexico. I've probably heard a lot about this in the news, but it's a viral infection in the same family as smallpox. It doesn't usually cause serious illness, but it can result in painful lesions or sores, and rarely results in hospitalizations or deaths. So it's not like COVID. There have been 0 deaths in the US. But it is a public health emergency because it is spreading in the United States and around the world. There's a total number of 6,617 cases in the US now. We only have 10 cases in New Mexico, but it can be spread to anybody. It's spread through close physical contact between 2 people, and anybody can get monkeypox regardless of sexual orientation, gender, or gender identity. Next slide. So the way monkeypox is spread is basically spread through skin-to-skin contact is the primary way it's spread, through somebody who already has monkeypox. So direct contact with the rash or scabs on the person's skin. You can also get it by contacting objects or fabrics like clothing, bedding, and towels, and surfaces used by someone with monkeypox. You can also get it through respiratory secretions during prolonged face-to-face contact, sexual or intimate contact, and including kissing, massage, or talking closely together. It's important to know that monkeypox is not spread through casual conversation or walking by someone with monkeypox. Next slide. So how do you know if you might have monkeypox? It usually starts with kind of a flu-like syndrome with fever, headaches, fatigue, muscle aches, and swollen lymph nodes. And then that's followed by a rash, not so much like a widespread out rash, but little bumps or blisters. These bumps or blisters that you can kind of see on the side here can look similar to syphilis, herpes, or those of you who've ever had chicken pox. It could even look like poison ivy. These rashes or bumps often occur in genital or the perianal area, and it also sometimes can take place without the fever or flu-like symptoms. Symptoms usually start, like I said, 1 to 2 weeks after being exposed to someone with the virus. When you know it's better is that the monkeypox can continue spreading from the time of your symptoms until all the sores or blisters have healed, and you get like a fresh layer of skin that's formed. That takes about 2 to 4 weeks. So it does take a while to get better from monkeypox, but most of the times it'll get better without even any treatment. Next slide. So what if you do worry that you do have monkeypox? If you have monkeypox, you should visit your healthcare provider or a public health clinic. It's really important that if you do have these symptoms, you avoid close contact with other people to prevent the spread, and until you know if you have monkeypox. So if you go to your clinic, they'll do a little test on your skin and send it in, and you'll know within like a day or 2 whether or not you have monkeypox. For more information, you can visit nmhealth.org and click on our monkeypox updates tab. Next slide. So what we're doing right now is actually monkeypox vaccination for high risk people at high risk, and it's starting to ramp up this week. So one of the important things to know that if you have been exposed to monkeypox, you should let, like I said, someone know, and actually you can get vaccinated for anyone exposed to monkeypox, and it's best within the first 4 days. That will actually prevent the monkeypox from happening. But then if you can actually still get vaccinated if you've been exposed up to 21 days, and that will reduce the symptoms. Right now, we're scheduling vaccines prioritized by those that have been assessed with highest risk factors as identified by the CDC. So people who are known contacts, as I've been sharing, because they either have been contacted through our public health department through investigation, contacts tracing, or if you call our hotline and get a risk exposure assessment, you will then be scheduled for a vaccine. No vaccines will be administered right now without an appointment, and that's really important to know because we're only vaccinating people who are in a high-risk group or if you've been exposed to monkeypox. So that's it for our vaccine update for monkeypox. I think that's it, David. Oh, sorry, one more thing here. Monkeypox vaccination in New Mexico. The vaccine we're using is called Jynneos vaccine. We have a limited supply, which is 956 doses as of August 2nd. We have 2,600 more doses that are coming out between August and October. And the usual dose is 2 doses given 4 weeks apart, but the second dose can be delayed to allow for more people to be vaccinated. So our goal is to try to get as many people vaccinated in high-risk groups to help contain the monkeypox virus. And if you are at risk for monkeypox and you're interested in a vaccine, you can call our call center at 1-855-600-3453. Next slide. And this vaccine, just so you know, is very safe and effective. And it just so happens that the vaccine was already FDA approved in the past 10 years for a potential smallpox outbreak. So it's actually a very safe vaccine and effective.
And Brianna, can you stop? Oh, you did. Thanks. Perfect. So Jody, I'll turn it back over to you. We're happy to take questions and about any of the topics we've talked about today.
Great. So I see a few questions in the chat. Susan Montoya Bryan from the Associated Press has her hand up, so we'll start with her. Susan, you should be unmuted and allowed to ask your question. After Susan, we'll go to Jared Ebenrecht from KUNM and then Ryan Botel from the Albuquerque Journal. Susan, go ahead and ask your question.
Yes, good morning. Thanks for taking our questions. Laura, this one is probably for you. I know other states have had issues so far with shortages of the monkeypox vaccine. So how many have we given so far? And are you guys concerned about having shortages as well here?
So thanks so much for the question. We've given out to all the people who've been exposed so far for the anybody who actually had a contact exposure has been given the vaccine, and then we are now vaccinating people in high-risk groups. We have approximately 250 vaccines given so far. We currently don't have a shortage, but I'm not saying we won't. The issue is that we're doing first doses first to try to get as many people as possible to cover the population that is at risk. So, could we run into issues as like other states? It's possible, but we're hoping, we don't have as many cases as other states. We only have 10 cases so far. So we are a little bit ahead of the game because, New Mexico is a smaller state. And so we got, the advantage of seeing that other states already started getting cases, and we then were able to prepare for this eventuality. Yeah, go ahead, David, sorry.
I'm not sure Laura mentioned this, but we haven't had any cases of monkeypox in New Mexico that people acquired in New Mexico.
That's a good
just
point.
yet. So that will likely happen, but thus far, we're not even at the point where the disease is actually spreading from one person to another within the state that we know about. So that's an important inflection point as well that will happen. But right now, it's really every single person has believes at least that they've acquired the disease in another state outside of New Mexico.
All right, Susan, any follow-up?
No, thank you. That answered my questions.
Okay, next we'll go to Jared at KUNM. Oh, I clicked on the wrong person. I'm sorry. Jared, you'll go after Ryan Botel. Pardon me. That was my accident. Ryan, you should be able to ask your question now.
Hi, thanks for taking our questions. Dr. Strace, I was wondering, you talked about how, COVID cases are pretty level, hospitalizations haven't been ticking up, but yet every day the state's reporting a pretty significant amount of deaths. So I just wanted to clarify, who exactly are we counting on those daily death totals? I mean, is that OMI confirmed that they died of COVID, or if someone's in the hospital with COVID but is being treated for something else and dies, would they be included too? Just want to make sure I have an understanding of who is exactly included in that death count.
That's a really good question. So, and let me start with the most important thing is we're reporting deaths on the day they're reported, not the day they occur. Because if we report them on the day they occurred, we'd actually have to go back and give you the full last 2 months of every death, and those numbers would change incrementally. So, there is a process that's involved. I'm a physician, or as a physician, we have to do this. We fill out a death certificate online, and then, but it's mainly based on what the treating physician says was the cause of death. So if someone comes into the hospital and has a heart attack and dies, they are incidentally found to have COVID, they might be reported if the doctor says COVID and writes it. We only have like 4 spaces to put out the causes of death. But if you go to the mortality report and scroll way down near the end, what you'll see, and this has been true since the beginning of the pandemic, 90% of the deaths are actually where the doctor wrote it as the first cause of death, which when I do that, I make sure I put in what it is I think the person died for. And then there's other conditions contributing. So if you're skeptical, you could just take 90% of the total deaths and say those are certainly caused by COVID, because that's what New Mexican treating providers put as the first diagnosis. But we wouldn't, for example, double count someone who died in the hospital. That every mortality from COVID is counted only once. And if we have time at the end, I could even share the latest data from the mortality report about the death certificate diagnoses, if you like. Bring it up. Does that answer your question?
Yes, that answers my question.
All right, thanks.
All right, thank you, Brian. Next, we'll go to Jared Ebenreich from KUNM, and then after Jared is Julia Goldberg from the Santa Fe Reporter. Jared, you should be allowed to unmute yourself and ask your question.
All right, thank you, Jody. Just confirming you can hear me.
We can hear you.
Thank you so much for the time. So I'll try to make the question succinct. When we're talking about, this builds on Ryan's questions, when we're talking about the mortality and the rates of that and the proportionality of hospitalizations and mortality, the New York Times, which is one place that you can follow the cumulative incidence of mortality over time, over these last 4 weeks, we've creeped up from 8th all-time mortality to COVID-19 to now 5th, rivaling, Mississippi, Alabama. Only locally Arizona's above us. So that is pretty astronomical. It's somewhere around 394 deaths per 100,000 people is now where New Mexico is at. So it begs the question, what's the acceptable level of transmission, people out of work, sick, hospitalization, and mortality that NMDOH is shooting for with COVID-19?
Okay, so there's 4 questions there. So I think I can answer all 4 of them, and Laura, you can jump in if you like as well. So the acceptable level of transmission, really, we go by that CDC red line, I think which is currently at 28 cases per 100,000 people. So that's what we're using, and we are above that now. So as I showed in the graph in my very first slide, we're above that. So that's our transmission level we're using. I think you're already aware, even though you asked the question, that we don't track the number of people out of work. And so that's not data we have access to. Of course, my personal opinion is that the less people that are missing work, the better, which is why we continually talk about, getting vaccinated and staying safe, and go over that every time. An acceptable level of hospitalization is it's a tricky thing, because there's the idea of an acceptable level of hospitalization in a pandemic isn't really a concept we deal with. Like, we have data like at what's acceptable levels of, what percent of people should be hospitalized for, a heart attack. Well, 100% in the United States, but in England, it's different. So I think I don't, you're asking questions that we don't have exact data for. We do for the transmission rate, and the CDC has given us that boundary for a high level. And then let's say mortality, of course, I think any death is an unfortunate death. No one should die of the disease. The majority of people who have died from COVID were unvaccinated individuals, despite the fact that an overwhelming number of folks who have been vaccinated, a very high percent, 75% fully vaccinated. And I think that the whole concept of, how we manage something like a pandemic, where we don't have the usual control mechanisms in place, and it takes years, as we've seen, to get them in place. So we're not so much going by the numbers anymore. And I kind of say this at every press conference. We're more really focused on the impact it's having to our healthcare system. So I showed you the graph of hospitalizations. We probably have as many cases now as we did in January. We have 1/5 the hospitalizations. Our hospitals are handling that pretty well. We have 130 some open beds today for COVID patients, 35 ICU beds open today. So for us, that's good. But we don't want anyone in the hospital either. And so I think it's for me, I don't want to get COVID. I don't want to transmit COVID. I don't want to be hospitalized with COVID. I don't want to die from COVID. I've certainly had a lot of patients who've died from COVID, and then the last thing about the ranking of the states, then I'll see if Laura has anything to add, is, those are what the way they take those rankings are, they take the number of people who've died and they divide it by the state's population. It's pretty obvious, right? But it doesn't correct for age of the population. And New Mexico will be, I think, by 2030, this is like my area of expertise, so I really should know this as a geriatrician and a professor at the university. By 2030, New Mexico will be number 3 in the country in the percent of people 65 and older. So that statistic alone, and if we were number 5, and those were the only factors that would confirm that. In addition, we have the highest social vulnerability index in America, the highest state vulnerability index. So that I don't really pay a lot of attention to where do we rank compared to other states, because it's not corrected for all the individual population characteristics. We don't want, it's not a list we want to be at the top of, but I do believe that we're actually doing a lot better as a result of all the things we've done. We've led in testing, we led in vaccination, we led again in home testing around the country. We were on a call, not me, but some of our folks at DOH were on a call the other day, and they couldn't get anyone to prescribe Paxlovid, and we're probably prescribing as much Paxlovid as any other state in the country on a population basis as well. So it's not about what's acceptable because it's a pandemic. We'd like transmission and hospitalizations and deaths and people out of work, sick, to be as low as we possibly can. But I think what we're trying to do is encourage everyone in New Mexico to do their part, to wear their mask in a time that's red or yellow, to do all those things, and to get on board to help us all working together to minimize all those numbers that I mentioned and that you brought up. So long answer to your 4 questions, or 5 maybe even. And I think that we'll continue to monitor everything closely. We have, I forgot to say about how we lead in data as well. I mean, we're leading in a lot of very, very good things. And unfortunately, based on our population characteristics, I'm not happy with our ranking in deaths. I mean, if I had my way, if it was possible, I wouldn't want anyone to die from COVID. So back to you, Jody.
All right, next we'll go to Julia Goldberg at the Santa Fe Reporter. And Julia should be able to ask your question. She has a clarifying question, and then I think she has another question.
Thank you, Jody. Thanks, Dr. Scrace and Dr. Padahan. Dr. Scrace, I just wanted to make sure I understood something you said earlier, and then I also had a question about monkeypox for Dr. Padahan. You mentioned at the start of the news conference that I think I might have misunderstood you, but you were saying something about this was the first time we had all the three colors on the CDC map, but we've had all three colors since the first week of March when they started it. I mean, we have more green than we've had previously, but so I didn't know if I misunderstood what you were saying.
Yeah, I think I misspoke. You know, the map, so there's two maps, as you know, Julia, and the one I look at like all the time is the healthcare provider map, because I'm a healthcare provider. So
Oh, I see.
I think that's a good correction, and I would trust your, I said I was talking about the map that you're talking about, but I wasn't. So
You're
thanks
talking
for
about-
correcting
I
me
get
on
it.
that. And I believe you're exactly right.
And then maybe could you just clarify also though, just I guess as a follow to what you were just saying to Jared, do you think the CDC community levels map is a place where we would look to kind of detect endemicity, or does the changing factors mean that we're not even thinking about that anymore? I wondered if when you talked about a plateau, if that was kind of synonymous with endemicity.
No, I think we've been endemic with COVID since the summer of 2020, you know, or maybe spring, actually, technically spring. And when you haven't, I'm impressed with that word. I'm going to have to try endemicity on Wordle when the letters come up, because I didn't even think of that word. But an endemic state just means you have widespread community transmission, which we've had since the beginning of the pandemic. So I think that transmission component of community spread does identify that piece, and the two hospital components are separate. And I think the main reason why we're seeing a softening in the colors, you know, in some places, because case counts have come down a little bit, but hospitalizations are really low. So that'd be my answer to that. And then you have one for Laura too.
I did. I just wanted to make sure I understood, because Dr. Scrace mentioned that all the cases have been travel related. I wasn't sure if community spread has the same kind of profile in a disease that has such a different transmission mechanism. And then I guess I also wasn't sure, when you talk about people being at high risk, who those people are, if anyone can get it. I know that there's been, I think like 98% of the cases have been among men who have sex with men, but you don't seem to be identifying that as a group that should be seeking treatment or vaccine. So I guess I just wanted some clarification about what at risk meant in this context and what spread looked like in this context.
Great. So I can talk about community transmission first. So community transmission just means here in New Mexico that there was someone who had a case that they got it from someone in New Mexico. So that actually hasn't happened yet. And so that's good, because that means that it's not transmitting within the community. It's actually transmitting, like when you go somewhere else, you traveled, you got monkeypox, you brought it back, but then it hasn't spread inside our community. So that's community transmission. In terms of who we want, who are the people who are at risk right now for monkeypox, really, you're absolutely right that it has been in men who had sex with men and had multiple partners. That has been the group that monkeypox initially got in, but we don't want to stigmatize people. It's not that that's a particular group that it just happened to get into one group in particular first, but anybody who comes into contact with monkeypox is at risk of getting monkeypox. Does that make sense? So like if you have any of the spreading ways like skin to skin contact, sexual transmission with someone who has monkeypox, then you are at risk for getting monkeypox. So we want to make sure that people know that anybody could get monkeypox, but right now it's in one group in particular. And so that is a high risk group that we're basically when you call the call center, we call our call center and we go through a series of questions to identify whether or not you are at high risk of getting monkeypox at this time. And that's the group we're vaccinating first. I hope that answers your question.
I guess I just wasn't clear, like people would really be self-identifying as I'm at risk because I know that I had contact with someone with monkeypox, or I'm at risk because I had unprotected sex and I have no idea if the person had monkeypox, or I'm just not sure what the criteria is. Dr. Spice.
I was just, Laura can speak to this better than I can because I'm just hearing about it, but there are lots of ways to get the word out. And in this particular situation, we've had a pretty intensive communication effort with communities at high risk and our partners in DOH, with those who partner with DOH to help us get this message out. So I think, and I think, Laura, if you want to mention it, we just met with the communities yesterday to talk about messaging and how best to do it and which way to do it. But we've been communicating very directly and very strongly in a lot of different ways because in like all communication, the more you target the communication to the audience that needs to hear it, the more effective it is. Laura?
Yeah, that's what we have been doing, just like David said. We don't want to stigmatize any group, and like we shared, anybody really with those transmission mechanisms that I shared, and you just said yourself right now, right? Sexual transmission with someone who has monkeypox, skin-to-skin contact with someone who has monkeypox. We also have on our website a messaging toolkit that anybody can use. But yeah, so just like David said, we've been reaching out to the communities. I think that's kind of the way we want to address reaching out to people without stigmatizing anybody.
Okay, thank you.
All right, thanks, Julia. Next, we're going to go to Mike Smith. Mike, I believe, is with the Carlsbad Current Argus. Mike, you should be able to unmute yourself and ask your question.
Okay, can you all hear me now?
Yes.
We can hear you, Mike.
Okay, good enough. All right, good enough. All right. This is more for Dr. Sprace, and I think for Dr. Laura. And I mean Dr. Laura in a good term for you, okay?
Thank you.
Anyway, Dr. Sprace, I know when the virus first broke out into Mexico some 2.5 years ago, Southeast New Mexico was pretty high versus the other parts of the state. Can you address how Southeast New Mexico is right now versus other parts of the state?
Yeah, great question. I didn't know the answer. You sent it to us in advance. We had kind of a long discussion about it at our morning meeting today, and I might be fast enough to bring up the maps, but those epi curves don't display as well as I wish they did. So they're sort of delayed, but we looked at it really in detail. And right now, our sense is that the southeastern part of the state is pretty much at the same place it was before. But sorry, is it the same place that most of the other regions of the state, and we look at central, northeast, northwest, southeast, southwest. And so I am pulling this up and hopefully I can share a curve, but we did notice one thing that was interesting. And so it's good for you that you asked the question in advance. So I have this answer, but I don't think my explanation for why it is the way it is might be very satisfying to you. And again, I apologize. These are really small and you might have to take my word for it, but this is the Southeast epidemiologic curve since the beginning of the epidemic. This is that acceptable level of cases that Jared was referring to earlier from the CDC. And although they don't use that term, they they say high rate of spread. And then, so this is the Southeast and this is the Southwest. And we did notice this morning that while the Southeast and Southwest, and I can show you all the other maps, they're basically the same, are at about the same level of rate per 100,000. There was a delay in the uptick in cases in the Southeast compared to the Southwest, for example. You can see how it goes right up right at this point in time, whereas the Southeast, there was kind of a delay and then it went up. So I think one thing we've seen, and this is where the graphs don't display, but one thing we have seen is that the state has been pretty homogeneous. The CDC data does divide it up into colors, and that we have some counties who are traditionally higher rates. Sorry, this is the display issue I referred to earlier. But in any case, we think you're right about where everybody else is at the present time. So one of the problems I have with this, with Zoom on my setup, is I can't unshare my screen. So Brianna, if you could briefly share your screen to kick me off, that would be great. Perfect. I hope that answers your question, Mike, but it's a really good question. We talked about it for a while, like, well, why would it be later? And the short answer is we don't really know, but if you had a lot of cases before, you might still have some immunity, whatever, but it seems about the same as other quadrants of the state.
Okay. And finally, do you see the state going back to the certain health restrictions that were enacted back in 2020, or do you think those days are pretty much over and done with?
Yeah, I don't see that happening. It's really kind of funny, but I get a lot of email, and I have a folder now, for COVID emails, and it's been very quiet. Like I've gotten 0 emails asking to have the mask mandate reinstituted. And so I think that basically at this point, we have the tools we need to manage the pandemic. We're in a different pandemic than we were 2 years ago. We have readily accessible testing, even in home. We've got a much broader public awareness of symptoms. And I hope everyone knows not to go to work sick. My assistant got to work, felt sick, and went home before she even came in the building. Good job, Michelle. Nice work today on that. She did the right thing. We've got the vaccine that's made just a dramatic difference in the mortality rate and hospitalization rate for people who get it, and still making a big difference. And then we have treatments, which New Mexico is just really knocking it out of the park when it comes to getting people on oral treatments and still some of the monoclonal antibodies when they first get sick. So I think the vaccines and the monoclonal antibodies, and particularly the oral treatments, are probably why we're seeing that big drop in hospitalization rates, in addition to characteristics of the virus. But there's no discussions about that. There's no entertaining reinstituting a mandate. I certainly would encourage every New Mexican to know their own health status and take precautions. I've already shared with you when and how I wear masks, and at work here, because some of us are healthcare workers, we use the healthcare worker map, which is still pretty red, and are very, very cautious. So if everyone did that, I think we would have the pandemic well below that red line, and much, much less frequent hospitalizations and deaths.
All right, thank you, Mike. We have enough time for 2 more questions, and then I'll ask Dr. Scrace and Dr. Patahan to finish up with final words. We're going to go to Austin Fisher with Source New Mexico, and we'll end with Chris McKee at KRQE News. Austin, you should be able to unmute yourself and ask your question.
Hi, good morning. Thanks for taking our questions. The CDC is likely to update its COVID-19 guidance soon, including de-emphasizing social distancing, targeting testing guidance and quarantine timelines for schools, and increasing the focus on ventilation to mitigate the spread. How does this impact DOH guidance?
I'll start. I'll let Laura speak as well onto this, but I think our goal, particularly over the past year or so has to be as closely aligned with the CDC as we possibly can on everything. Unlike the beginning of the pandemic, where nobody was really sure what to do, and we led in a lot of different areas. And I will confess, in the past year, we were out ahead of the CDC by a week and recommending boosters for everyone rather than a select group, and that came through. But we look at every CDC guideline. Our goal is to conform to it. If there's something in there that wouldn't work well for our unique and diverse and socially vulnerable New Mexico population, we do tweak it from time to time. But I would predict that, given all the research and data that's now going into these recommendations, that the DOH will sit down with the new guidance, start by assuming we're going to accept it, and then make changes where we feel like it wouldn't apply to our population. And Laura can talk a little bit about the extent to which our epidemiologists are in contact with the CDC every day and every week, and actually contributing to these discussions.
Yeah, so absolutely what David said is correct. Like, we always follow what the CDC does, except like in that case of the boosters, we're 1 week ahead. So for the most part, we are in constant contact with the CDC. We have weekly calls with them, sharing our data. Our data is shared constantly with the CDC, just like many other states. And and we give feedback on those issues. So the CDC will come to all the states and say, hey, what do you think about these new guidelines? Give your feedback. We'll always give our feedback along with other states. So I think it's not a one-way street. They also do reach out to us and other states to get feedback on their guidelines.
I think it's worth just taking a minute to take this opportunity to compliment our epidemiologists. If you look back over the past 2.5 years of this pandemic, my view of what's happened in our state is they have painted almost the whole painting every week and every month of how we respond to COVID. And then from time to time, the background might be filled in by additional data from the CDC. But I think what allowed us to be, start ahead and stay ahead was the consistent forward-thinking guidance we've gotten from our epidemiology team. And the trouble with mentioning any of them is then you feel bad. But I know personally for me, Chad Smelser and Dan Sossin have been just amazing supports. And Chad, if he were on, would tell you that I kind of grilled him today at great length. All my questions are, how are you thinking about this? What's your opinion about that? Like, do you have any explanation for this? And they just always come through. So there's an awful lot of people behind the scenes that help us every day that you don't see or talk to, but they're really brilliant people that have served our state and our population extremely well. And I just, since you brought it up, I wanted to mention that.
All right, thank you, Austin. We're going to go to Chris McKee with KRQE News, and we'll close with Chris McKee. You should be able to unmute yourself and ask your question, Chris.
All right. Hello. Thank you, guys. Good to see y'all. One question I had come up watching the presentation was regarding the Omicron booster. And I just wanted to see if perhaps you could forecast what you think we should expect. See, will there be booster clinics? Do you think there will be high demand, or is this going to be mostly something that people will go to Walgreens or whatever pharmacy, to get these? Just as each sort of phase of boosters or shots have rolled out, they have all kind of changed a little bit. And so I guess I'm just curious if you could give us a picture of maybe what you guys are planning on and what people should expect for those Omicron boosters, and remind us of when again, please. Thank you.
Yeah, I'll start. Laura, as you all know very, very well, was the person who led us along with the governor's encouragement and insistence to be number one in getting people vaccinated in the United States through the first 6 months when they were available. So she really knows all the ins and outs. It's a great question, Chris. A really good question. I have not seen the data from the preliminary trials yet. Usually that comes out when the FDA starts reviewing the vaccines. I've heard it's promising, and I think the answer to your question really will depend on the data. If the booster shot actually prevents, 99% of hospitalizations and deaths, then I anticipate a really quick, brisk uptake and a very rapid response in the part of DOH and our delivery systems who partnered with us to get those shots into arms. But I can't answer that without seeing the data just yet. But I think I've been talking now for a year maybe about this day that might come when the COVID vaccine would kind of be like the flu vaccine, where we get an update every year and it's a different set of, flu viruses that we get vaccinated for, 3 or 4 usually. The ones that were most common in the Southern Hemisphere, 6 months ago is what goes into our arms. And so I think the idea that we're now evolving to having variant-specific vaccines is amazing progress and could, in my opinion, this is my opinion because it reinforces my belief, I suppose, but we'll likely predict that we'll get into a more annual pattern of boosting people against the latest versions of COVID. But as to the DOH response, there's no better person to talk about this than Dr. Parahon. Laura.
Thank you. Yeah, like David said, we have a huge team at the Department of Health that runs our vaccine program, and all the other Department of Health staff that have supported and have done an amazing job. So what we have right now is that the majority of the vaccines that are being given are still pharmacies. So I still think that's still going to be the main way people get their boosters. But we are on the ready. We basically have a fund set aside, especially for people who are uninsured as well, in difficult to reach areas. We would like to make sure that we have mobile teams still ready to reach out if there's a huge demand. So that's kind of how we've been running things. It's the same thing with the 6 months to 4-year-old vaccines. We were ready in case there was a huge demand. Unfortunately, there hasn't been a huge demand, but we are basically ready to see what happens with boosters and just meet the demand where it's at. There's usually like a 1 or 2 week lag, obviously, because we have to get all the teams up and running, but we'll be ready and tracking the data. Like David says, if we see a huge amount of need in, like, let's say Las Cruces, Santa Fe, Albuquerque, we'll set those up, additional sites. But we're not quite there yet, but when we are, we'll be ready.
And I can say that I'm going to sign up right away. As soon as the website goes live, I'm going to get in line for my shot.
All right. Thank you, Chris. Dr. Scrace, Dr. Petahon, any final last words?
Go ahead, Laura.
Oh, okay. Well, I kind of want to build on what David said about our team at the DOH. I would say the whole team, our epidemiologists, our public health people, our facilities, everybody really stepped in during the pandemic. And I just want to thank all of them, because I think where we're at today is in large part due to like the huge efforts of our team here at DOH and the whole healthcare system and other systems that interface with that. And I think New Mexico is in a better place because of all the people who helped out.
Yeah, I would echo what Laura said, and just in closing say that this is really a community effort. This is a statewide effort. Everyone can reduce the transmission of COVID. Everyone can make their communities safer. Everyone can look on the website to see what the activity is, both DOH and CDC in their communities. And so I think the more everyone is actually everyone, now that we have all the tools that we need and potentially a new and updated vaccine, I think the more that we all pitch in whatever ways we feel comfortable with and fit our conscience, the more we'll be able to start looking back, which we can't do just yet on this pandemic, and say, we actually, there were a lot of people who got hospitalized. There were a lot of people who missed work. There were too many people who died. But it would have been much, much worse had we not acted as quickly and responsibly and decisively as our governor did and directed all of us to do over the past 2.5 years. So with that, I'd just say be safe. There's still a role for your mask. Don't forget it. Sorry, I've got my DOH background on. I'm at HST today. There's still a role for your mask. Don't forget what it is. And we'll see you in the future. Thank you.
Thank you again for joining us. Our next scheduled press conference is September 15th.